Hi, Marn.
Hello, everybody.
Welcome, everybody, to the MGH brain-PBM clinic round. Today is June 10, 2022, and it's my great pleasure to introduce Dr. Anne Liebert, adjunct professor at the Australian National University and a clinical scientist. Anne, please take it away.
Thank you. I would really like to thank Professor Casano and Massachusetts General Hospital for the opportunity to speak today about our translational research trials. And I'd like to give 4 case studies to illustrate the effect of photobiomodulation on the symptoms of Parkinson's disease. I have been researching photobiomodulation treatment outcomes for 10 years, and for the last 5 years concentrating on Parkinson's treatment. I've been treating pain and wounds and inflammation for over 30 years. So I'd like to disclose that I'm a co-founder and shareholder of Microbiome and currently scientific advisor to the company. Symbex's primary objective is to commercialise therapies to reduce the symptoms of Parkinson's disease. Research has been supported by Microbiome, Parkinson's South Australia, the SAN Foundation, the CHI Foundation, and private donors. And Simbex has a home laser device which is CE marked in Europe and ART listed in Australia for the relief of the symptoms of Parkinson's disease, as well as fibromyalgia, pain, and tissue repair. I'd like to introduce photobiomodulation for Parkinson's disease and how it can decrease the symptoms, including pain. I'd like to talk briefly about the mechanisms of Parkinson's disease and the role of the microbiome potentially, a brief overview of one of our clinical trials, and then 4 case studies, 1 case study from the clinical trial and 3 integrating photobiomodulation with multidisciplinary medical management. All of the patients gave consent to present the results, and 2 gave consent to be named and presented as part of their TV segments that they have done. So after finishing my PhD in 2016, the use of photobiomodulation in the treatment of migrainous cervicogenic headache, I was invited by a professor of cardiologists with support from the neurology department at the SAN to take a position as director of photomolecular research. I am presently the coordinator of research at the SAN, and that the reason the SAN was interested in utilising photobiomodulation is that they started treatment in 1903 after Dr. Kellogg visited Dr. Finson in Denmark and introduced the light therapy boxes in 1903 when the hospital started. There has been continuous use by physiotherapists since 1903 until now through ultraviolet treatment for wounds in the 1940s, the bilirubin jaundice treatment, lymphedema and pain in the 80s, as well as when I started in 2016, we started in cardiac applications and also oral mucositis. We then pivoted in 2017 towards looking at trials in Parkinson's disease, which has resulted in the current protocol that we're talking about. So there's been medical applications, as I said, since 1903, and we now call light treatment photobiomodulation. And there's now this increasing evidence for neurological benefits. The risk-benefit analysis is excellent with only mild transient reactions only, and Professor Casano has well reviewed this in 2019. So the original work that I did on ion channelopathies at the membrane, and particularly pertaining to headache and the pathophysiology, has led to this research and the interest by the cardiologist in cardiac channelopathies. So the mechanisms beyond cytochrome C oxidase and the metabolome has also been part of my interest. And Professor Michael Hamlin and I, as part of our latest issue of PPLS, have looked at photobiomodulation therapy mechanisms beyond cytochrome C oxidase. This diagram is part of my work in heart treatment and looking at how the photobiomodulation modulates myocardial reperfusion injury and the mitochondrial effects as well as the non-mitochondrial effects. It works through the ion channels, through the cytoskeleton of the nerve and other structures. It has remote treatment effects, systemic actions on inflammation, circulating molecules, as well as stem cells. So what I'd like to really talk about today is its application in Parkinson's, and particularly symptoms of Parkinson's, which can include pain as the first treatment, often present up to 10 years before the motor symptoms become apparent, and they represent sensory system dysregulation at the early stage of the diseases, which interferes with quality of life. Treatments for Parkinson's, including deep brain stimulation and medication, do not generally help with the pain. And there is very good evidence for photobiomodulation and pain, and a good basis for its action. And my colleague, Roberta Chow, did the early work in the 2006, and this is a diagram of her neural blockade, similar to lignocaine injections that was done in vitro. And Professor Anders' lab with Professor Hollander looked at an in vivo model in a rat and looked at the relief of back pain as being a result of this cytoskeleton neural blockade. So with Parkinson's, as well as nociceptive pain and the pain of dystonia or muscle spasm, there is also neuropathic pain as well as central pain. So central pain is a portion of the symptoms that are very similar and can include fibromyalgia. This is present as a lack of inhibition of signaling of the oscillation networks in the brain, and there is a loss of accompanying gamma waves. This is in the basal ganglia and also involves increased pain sensitivity and a disruption of many of the networks, including the default mode network, the salience network, and the executive network. And patients with both Parkinson's disease and fibromyalgia central pain represent a distinct subgroup. Their Parkinson's is more treatment resistance, they take more medication, both analgesia and anti-Parkinson's medication. And these patients have a higher prevalence of depression, anxiety, and dementia, and pose a big challenge to the medical and allied health professions. So many of our labs have looked at network changes which are dysregulated in Parkinson's disease. So Professor Mani Naser has looked at it in aphasia. Professor John Mitrofanis has looked at it in normal motor function in normal patients where they can increase finger tapping with photobiomodulation on the transcranium. And Linda Chow has also looked at the work with Lou Lim on the change in connectome. So the question that we pose, because this is what we're particularly interested in, microbiome mechanisms of photobiomodulation in photobiomics, can the central pain mechanisms also be changed by the microbiome? So we have done this work both in an animal model, in mouse model, and now a retrospective microbiome analysis of all of our patients in our two major trials here in Sydney. So this diagram that my husband spent 6 months tabulating all the DNA showed that the effects of all of our participants. Each column is a participant, each colour is a genus of bacteria. Each participant has 2 columns for before and after 12 weeks of treatment. The 2 wider columns are the average of all participants. We can see many changes, but there are large differences between participants, meaning that there were only one significant change and other changes as trends. The Firmicutes to Bacteroides ratio, which is often a ratio of good microbiome health, improved in all participants. This is sometimes thought as a proxy for good gut health. Bacteroides generally increase, as did other short-chain fatty acid producing bacteria, generally considered good bacteria. Potential pathogenic bacteria, considered bad in the microbiome, decreased in most participants. So is the gut microbiome interacting with the proposed photobiomodulation on the symptom of pain? So we have seen that the microbiome metabolites, including GABA, alpha MSH, which is the major anti-inflammatory metabolite, dopamine, serotonin, tryptophan, and as we've talked about, the short chain fatty acids, have all changed with a good and poor microbiome. It involves an intact gut lining, good mucus layer, and healthy epithelial cells that signal via the vagus nerve to the brain. And they're altered in individuals with both fibromyalgia and neuropathic pain, both present in Parkinson's patients. So just briefly talk about our clinical trial history and talk a little bit about the results of one trial. So we had a trial where we just treated transcranially with laser in Brisbane. We treated transcrania with LED, with a V-light and a laser in Adelaide. And we treated 7 patients with just remote abdominal and cervical treatment in Sydney. These are all published. At the moment, we have a randomly controlled trial on just transcranial treatment undertaking at Sydney, and we also are starting one in Canada with Anita Saltmarsh and Marnie Nazer and Ola to look at both transcranial and abdominal treatment.
And if I may, a quick question there. What's the difference in between microbiome and abdomen without microbiome?
Whether we tested the microbiome, and we haven't tested some of the new one will not be tested.
Got it.
So we have only done outcome measures and not the microbiome DNA analysis, especially because of COVID.
Thank you.
So these are the published papers. If people are interested in the outcomes, the new ones have just been published in PPLS and the microbiome in the Journal of Personalised Medicine. But we're most happy that BMC Neurology published the improvements in clinical signs of Parkinson's disease in all our outcome measures. The devices we used in the clinic was an irradier laser dialed down to the parameters that we have looked at over the last 5 years to be effective. We used a V-light helmet in Adelaide. We've used a well-read helmet in the follow-up treatments, and we've just recently started with the 3-year outcomes looking at another helmet that we have devised. And the home treatment is by a Simbex PD Care laser. So the Adelaide clinical trial, as we can see the outcomes in red. And we show generalized improvements in most of the participants. The results are presented as medians with interquartile range and brackets. Most symptoms improved. Red is significant improvement using the non-parametric Wilcoxon signed ranks test. Even after 1 year, significant improvements, especially in timed up and go and cognition, but most others, even if not significant, were still improved above the baseline. Balance was generally much improved, but the high variability meant that it was not significant. In this slide, we see the individual changes with treatment. This is arguably more important than the average changes, since these are the changes that each individual sees. We used a measure called the minimally clinically important difference. This is defined as a change that makes a significant difference to the participant. The calculation for this is an improvement of more than half of the standard deviation of the combined baseline measures. So anything that is green is an improvement, darker green is a bigger improvement. Beige is no change, and orange is a decline in the measure. The important point is the number of green squares after 12 weeks and 1 year, especially for timed up and go, walk test, and MOCA, which is a cognition test, even after a year where you would expect declines. And also, there are no negative changes as well. So I'd like to go just through a few of the tests. The timed up and go, which is a test of gait and balance. The participant stands from a chair, walks 3 meters around an obstacle and returns to sitting. The less time is better. You can do it accompanying carrying an object, which is dual tasking, and also counting back numbers, which is also a cognitive dual tasking test. The times up and go shows a decrease in the time taken at 12 weeks and a further decrease at a year of treatment. So 12 weeks was in-house treatment, 1 year was home treatment. For our 2-year follow-up, we had 7 out of 12 participants who returned for retesting. 5 had continued home treatment and 2 had not for different reasons. For our 2-year follow-up, we had the 7 treatments, and for the 3-year follow-up, we had 5 patients that we were assessing. So after 2 years in times up and go, the 2 years that people that discontinued were not back to baseline, but they didn't further improve. And at 3 years, we had continued improvement in those participants. This is the times up and go carrying a glass of water, where there was also a similar improvement over the years. And if you note, at 2 years, the people that had the treatment was still discontinued for 1 year, was still not back to baseline. And the same trend is shown with the timed up and go cognitive test. And we're very pleased at the 3-year follow-up. So this is perhaps the most exciting of all of our results. This is a cognitive test, the Montreal Cognitive Assessment, where the result is maximum out of 30. The average at the baseline was 26.5. After 2 years, the participants who continued were still improved, but 2 participants who did not continue treatment did not show a drop in cognition. After 3 years, there was a 1-point drop in 2 of the participants. The remainder stayed at 30 out of 30. There was a similar but slightly more mixed effect on the step test. That's lifting the leg up as many times as you can in 15 seconds. And they showed an improvement in faster is more is better at 12 weeks after 1 year, further improvement after 2 years, except for the people that discontinued. And there was a maintenance and improvement after 3 years. There was a difference between the affected and the unaffected leg. So I'd now like to talk about the first case study, Margaret, who is a participant B2 from Adelaide. She was aged 72 at the start of the trial. Her initial PD trial assessment, she was recruited from Parkinson's, South Australia. She was assessed in UPDRS by a neurologist, and she had a 7-year history of idiopathic Parkinson's disease. She had replacement dopamine medications and standard care, and that was unchanged during the 3 years, and her comorbidity was right hip arthritis. The trial intervention, including screening and assessment by the independent neurologist at home in YAR stage 2 to 3. Her husband, as the caregiver, agreed to report on her progress, which was a trial requirement. 14 weeks, this was a waitlist design, so half the 6 people started immediately and 6 waited to look at the Hawthorne effect. So she waited for 14 weeks and then had 12 weeks of clinical treatment. She continued the home treatment after clinical treatment for 3 years. We completed trial assessment before treatment at 4 weeks, 12 weeks, 1 year, 2 years, and 3 years. The symptoms that were most clinically relevant to Margaret: she had severe diarrhea and constipation. This almost prevented her attending the trial, because the 15-minute drive to the clinic, she would have to stop at a service station to go to the bathroom. She also had a lack of volume in her speech. She had dyskinesia and asymmetry of motor control, especially in gait, which reduced her activity of daily liver function. She had a loss of confidence to go out at social functions because of the diarrhea. She had some mood disruption and anxiety relating to the disease progression. So these are her particular results. And remember, 2 of these years is during COVID. So these were the averages, and this is Margaret. So at 12 weeks, she improved. At 1 year, she was improved, but not back at baseline, a little bit lost. At 2 years, she was further improved, and at 3 years, she was still well below the 1 year improvement. This is in timed up and go. Her results for cognitive, remember 30 out of 30, and 2 years of this is during COVID. She maintained 30 out of 30 for the whole time, from being at a 29 to start. The step test in the unaffected leg improved after 12 weeks, then again after 2 years, and then still above baseline at 3 years, with the unaffected limb still maintaining its improvement. So the summary of improvements for Margaret: she was a good responder to photobiomodulation. The improvements in most assessments were assessed, especially gross motor. She maintained the improvement, and at 4 weeks she had improvement in her most severe clinically relevant symptoms, including her GI symptoms of diarrhea went into full remission and did not recur in 3 years. Her left-sided dyskinesia and gait improved, and she had not had a sense of smell for over 3 years, and she retrieved her sense of smell at 4 weeks, and that continued to improve over 2 years. Interestingly, that is corresponded with the changes in the microbiome at 4 weeks that we noted, but much more research is needed to make any more statements about that. So this is film from her study, which is given permission for us to have. The first video is the first day of treatment, where she has had no treatment at all prior to treatment. Note her movement of her hand pushing her bag against her leg. This is within an hour after the first treatment. Which was very surprising. And this is after 2 years of treatment on the reassessment. So I'd like to just share, the university was contacted by Channel 7, and Margaret agreed to be on a small segment talking about her experience that she's happy to share.
I always used to have this sense of I could take on the world. I was always a very positive person, and Parkinson's tends to make you fearful, anxious. And since the treatment, I'm back to being my old positive self again, and that's half the battle, because no matter what you've got, if you can look at the glass half full, you're halfway there as far as conquering it and not giving into it.
Margaret Jarrett is not the kind of person to give up. After living with Parkinson's for over 10 years, she jumped at the chance to be part of a trial for a radical new treatment using infrared light.
My voice was very soft and croaky, and it was very slow. I was very slow in moving and pulling my jeans up. It was like you think of something to do and you do it, but it'd be like in slow motion, a delayed reaction before it would actually happen. And using the laser has brought everything back to how it used to be.
Obviously, the light has done amazing things for my speech, my sense of smell, and yeah, my handwriting, and my general demeanour has been more cheerful than it was.
George Wilcox had a career in chemistry and was not about to let Parkinson's take over his life. He did his own research into light therapy and started using an infrared skull cap at home.
Well, I did know about the fact that near-infrared light can penetrate flesh and bone, so I wasn't too sceptical at all. It gets right down to, believe it or not, into the cell structure in the brain and affects what they call the mitochondria in the cell, which in turn increases the amount of neurotransmitters. And I'm coping better every day. I'm doing just that little bit better. And I'm stopping declining. That's the most important thing, because I was a mess when I first got diagnosed, didn't want to get out of bed.
After a month, I had my sense of smell back. I went to bloating, and of course there's the usual sausage sizzle, which I'm used to looking at, not being able to smell the onions. And I could smell the sausages and onions, and I said to my husband, I could smell that. And I was all excited.
And George Wilcox also gave permission to be on this talk, and he was a patient from Parkinson, South Australia, not on the trial, but had been using a helmet for 2 years, and then had started with the abdominal treatment and got some further improvement in his gastric symptoms. So the next 3 case studies examples of interdisciplinary collaboration between neurologists at the hospital, the physiotherapist and the other physiotherapists in terms of exercise treatment. And I'd like to go through 3 of them. So Mr. A is a case study. He was referred by a neurologist. He's 72 years. He'd been diagnosed 10 years before and looked after by this neurologist. He was then interested to discuss the microbiome and his gut-brain axis in Parkinson's disease. The ROCA and the mini-mental was administered by the neurologist, who then referred Mr. A to myself for photobiomodulation titrated treatment and for PD warrior targeted exercise. He had comorbidities of a previous bowel cancer, which was in remission, and he had a colostomy bag for bowel resection. So the neurologist assessment prior to this 6-week treatment was that he was frailer and more stooped than 1 year previously, and this is during COVID. He had significant extrapyramidal dysfunction with rigidity. He had reduced performance of sustained tasks with his hands and fingers, including dystonic twisting of his right foot when he was using his hand. He had fatigue and lightheadedness after breakfast. He had postural intolerance that was measured by a blood pressure monitor. He had medication of Carvia, Zanadep, and Stalvia as his medication. So he was referred for a slow onset treatment, considering he had a colostomy for the remote gut and cervical treatment. And he had targeted group exercise for acquired resilience for motor and non-motor symptoms from PD warrior. So the treatment regime was titrated for remote and gut and C2. GAP began with a test dose. It started with 5 points at 3 joules per point. It was gradually increased over 2 weeks to 7.2 joules for 9 points, including the neck. And after 4 weeks of the treatment, he began home treatment 3 times a week. The approach that he had with exercise at the same time was one-on-one physiotherapy, then group classes and regular home exercise program, which is high amplitude exercise and effort active exercises tailored to the presentation for dexterity, amplitude, dual tasking, and reactive balance. After 6 weeks with 11 sessions of PD warrior exercise and 5 treatments of PBM to abdomen and neck only, the neurologist and then 2 weeks of home treatment, the neurologist's reassessment was significant improvement in his appearance, his posture, less stooping, his blood pressure was less unstable. He had improved walking, improved sustained finger and home motor tasks. He had improved cognition on mini-mental to 28 out of 30, but the patient seemed completely unaware of the improvements. His partner, although, did notice the improvement. In my physiotherapy assessment, his walking speed had improved and his hand function had improved. After a further 6 months without exercise because of COVID, we weren't able to have those classes, but continued photobiomodulation to the abdomen and neck only, home treatment 3 times a week. The neurologist reassessment was maintained improvement Medication was maintained the same, but the exercise was to be increased where possible at this stage. So the assessment by the PD Warrior physiotherapist at the Advanced Rehab Centre was there was a very, very slight decrease in walking speed with slow and fast walking. There was a slight improvement in walking speed where there was a dual task manual and cognitive effect, as well with carrying a cup, and the balance was essentially the same. So we thought that Mr. A had an excellent response, particularly when he combined the treatment of exercise and PBM. It was a perfect example of an interdisciplinary collaboration with the patient at the forefront, initiating the treatment with the neurologist, and he was able to have the home treatment during COVID. But the cumulative effect of exercise and photobiomodulation, we think, is optimal. So case study 3, Mr. B was also referred by the same neurologist. He was 68, he'd been diagnosed with 5 years. He attended the photobiomodulation clinic. Actually, he referred himself and then was assessed by the same neurologist on the 6th and 7th, 2021. He had been on a previous clinical trial of interest, which was very good for us because he was looking at how the microbiome changes with all the different medications for Parkinson's. He had no comorbidities, and he had also been using a V-Light for 2 years prior to my meeting him. His symptoms were still tiredness, lack of energy, tremor, tightness, dystonia in the calf and leg, hemiplegically, and his mood and motivation had been impaired. His medication was Cifril, Xadago, and Stelivia, and he had been using the photobiomic V-Light helmet. So after 4 weeks of clinical treatment, he began the home treatment to the abdomen and neck and continued his helmet use more consistently in conjunction with advice. And the neurologist had an opportunity to see him after 6 weeks of this treatment. And since the last reassessment, which was 1 year with him, the neurologist noted objective improvement in gait, tremor, walking speed, non-motor symptoms of mood and motivation. He felt an increased sense of self. He was no longer considering looking at deep brain stimulation and keeping that as an option in the future. And he asked if he would really like to reduce his medication because he felt better. And the neurologist's quote was in his report, his improvement has coincided with his commencement of abdominal laser. He's also an example of good interdisciplinary therapeutic alliance because he had a planned 3-month yacht trip. He was a yachty, hadn't travelled for 3 years. He now felt he could run up the hill. He had a positive effect of his wife and their ability to be able to go on their trip. And the neurologist gave him a roadmap to reduce his medication after his full assessment of the laser protocol on his trip. So he wanted to just change one thing. So case study 4. Is Chen, who's also agreed for her film on the news to be used. She's an example of an interdisciplinary therapeutic alliance between her general practitioner, her specialist neurologist, a pain doctor with an acupuncture specialty, myself, and a specialist PD exercise class. She was 55 when she was first seen. It was 2 months with previous treatment by the laser and other acupuncturist. She had idiopathic Parkinson's disease that had been diagnosed for 2 years. Her occupation was a classical musician. She had mild right-sided tremor, right calf dystonia affecting gait, right arm dystonia affecting her fine motor, which particularly her piano playing. She had constipation and gut discomfort and she had a family history of Parkinson's where her father had passed away. Her comorbidities, she had a 20-year history of thyroid cancer, which was in remission. She also had cervicogenic headache with accompanying symptoms of photophobia, vertigo, and occipital pain. Interestingly, migrainous headache is a risk factor for Parkinson's. So the intervention, we gave 2 weeks of intensive abdominal and neck protocol in the clinic 3 times a week without transcranial treatment, and she continued with home treatment after 2 weeks. So after 2 weeks, all tremor had ceased. She lost her calf tightness and could walk normally. She had reduced headaches. After a further 2 weeks, she found that her piano playing had improved and she did not miss any notes. She now attends once a month for the 18 months of acupuncture medical treatment, and I give her gentle osteopathic physiotherapy for her cervicogenic headache. She's had no deterioration of the improvements despite the COVID lockdowns, and she has been referred to a more specialised PD warrior for exercise intervention in the last 3 months. And this is her story.
A Sydney hospital is recruiting Parkinson's sufferers to a trial, a form of light therapy that's showing promising results. The treatment can restore speech, movement, and sleep, and all from home.
Classically trained pianist Chen is back.
And I don't know if you want to try to restart the video. Oh, I think she just froze actually. So I assume that they will try to come back in.
While we're waiting, Paolo, I missed the parameters of the like the wavelength.
Yeah, the wavelength.
So I thank you for all your interest in our photobiomodulation treatments. The research was made possible by support by Microbiome, Liebert, Parkinson South Australia, and our private donors, as well as the Ethics Department of the San Hospital, our investigative researchers, and our wonderful participants. The interdisciplinary collaboration is possible due to the San Hospital Research and Governments Department, PD Warrior, especially Mel McGonigal, and the neurologists that we work with, including Professor Jeff Herkus, as well as the patients who have agreed to share their experiences.
Thank you so much, Chen. I mean, these cases are so encouraging, as well as your clinical trial data, and very promising. There were already some questions that were rising in that little time frame. So I see here that Taiwei has a question. Why don't we finish with the prior question? I don't know, either James or Attila, if you want to restate the question for Anne, and then we move to the others.
Well, I asked about the parameters that the near infrared light used, and responded to it. My other question was more of a perhaps self realization that the visible light, red light, which was also used in an ASD double-blind study, I think from Cuba. They used light in the visible range for a very short duration, and but I did not, I guess, to this point, and still have a hard time, wrapping my mind around that, understanding that visible light being able to penetrate and affect the change inside the bone and skull and skin, under the skin. I did not expect that, and I don't understand still, like, something out there and in the nature.
So I think visible light is an allosteric switch. If we get up first thing in the morning, and at 6 o'clock we have the red light of dawn. Our serotonin and all our metabolites in our brain are completely different to 12 o'clock. So the visible light is an allosteric switch. Certainly in bright light therapy for Parkinson's into the eyes, it has an effect on Parkinson's symptoms at all, and a little bit of sunshine on your shoulder makes you happy. So I think what we're just doing is tapping into an allosteric switch of influencing our circadian rhythms. But we're a long way yet from looking at all of the coding, but I think that at least we have some protocols that appear to work. I think many other protocols would work, but these are the ones that we've been using. So the parameters we've used have been 904 nanometer multi-pulsed laser. We did all those experiments in mice first, and from the experiments in mice and the optimal wavelengths was how we devised the protocol. And then we were able to emulate that in a home treatment. But certainly in mice, in terms of the microbiome anyway, LED did not change the microbiome. Red light laser changed very little, and there was a difference between all the wavelengths that we tested in the lab. So that might be different. Mice are not people, but that was the best information that we had to do the trial.
Just to follow up on this, do you think that so the visible light has an effect here through the retina, or?
I think through the retina, yes, through the connections to the brain, but I treat professors who don't have any eyes, haven't had any eyes since birth, and so I think the non-visual phototransduction cascade through the opsins in the skin and in the hair follicles are also part of it, all the opsins within the nervous system and within the circadian rhythms. And we did talk about it briefly before, the biophotons within the body that are evoked as part of the downstream metabolic process are also. But of most interest, if you're born in the north of Norway or Sweden or in the south of Tasmania, your risk of developing Parkinson's is depending on your, one risk factor is depending on your month of gestation. Certainly, and that's the same for multiple sclerosis and for the expression of schizophrenia.
Could you repeat that? It correlates with the month of what, or the length of what?
Of gestation, when you're being born. And so does that influence the microbiome prenatally or other metabolome factors of your epigenetics? But it's definitely a risk factor. And there are 5 axonal guidance genes. They're predicating your incidence of Parkinson's. If you have mutations in all 5 of them, it's predictive of date of onset of Parkinson's as well. So I think embryogenesis and those perinatal times with light activation is crucial.
I would love to read about that.
I can send you all that literature.
Thank you. I'd love to.
And Taiwei, I know there are a few other questions. If you want to ask your question, hi.
Yeah. Likewise, I'm also very interested about. I mean, in the field relevant to how both visible light and invisible light can be kind of influence our behaviors. But that being said, I'm particularly interested in like Anne, you just mentioned in your case study saying that I mean, during the COVID period, of course, the patient cannot come to join the physiotherapy or other exercise training. You're kind of using this as a, I mean, this is definitely something that we need to explore more about. But would you comment more? I mean, I feel the pain of this COVID thing. I mean, in many of my studies, my previous study in Taiwan is largely influenced by COVID, and my current study in the UK is also kind of influenced too. So could you comment a little bit more about how COVID influenced your patient and your study?
So luckily, our study was just finishing at the start of COVID, so I was able to do all of the 1-year follow-up. The 2-year follow-up was the Adelaide trial. We didn't have COVID in that second year, so they were not locked down. So I think that was also exhibited. Certainly the Sydney trial, I haven't got a 2 or 3 year follow-up, but I would anticipate that they would not be as well if they haven't been able to have the exercise. But I agree with you. I think light can be an exercise mimetic when we can't exercise, but I really feel that the combination of the exercise and the PBM works better for the acquired resilience. And I think the small amount of light on the membrane is a small challenge to the body that the body then overcomes larger challenges. I think that's how it works, and I think that's any light, which includes just normal light. As well. And we know that from seasonal affective disorder, if we don't have the right amount of light, we're much more likely to depress, and we have to use light bulbs to improve that. So I think it's just generally there should be optimal amounts of light. And interestingly, that with the multiple sclerosis trials in mice that Jerry-Ann Lyons did, when she started looking at some of her results, some of the mice were not getting better. And so she looked at why was this? And those mice were getting the treatment in the afternoon. So you've got to look at the circadian rhythm cycle, and when you're applying the light from your own light rhythms and your timeless sort of proteomics.
Right. So regarding this light and exercise synergistic effect, is it something that it just fail, or you have some publication regarding this?
There's many publications that show changes to the microbiome with exercise, and there's many articles that show changes in Parkinson's symptoms with exercise. So what we're most interested in now is looking at are they cumulative, separate? Do you need them both as well, or are they just mimetic?
Yeah, that's right. Thank you.
Thank you. So we have only a few minutes. Fred, go ahead. I see.
Hi, just thank you, Anne. Wonderful presentation. And I just wanted to ask, is there any transfer of this treatment to long-haul COVID?
Yes, I've treated maybe a few dozen of long-haul COVID in Australia. We haven't had the first 2 waves, but I'm expecting a lot of them. I think Anita has also had experience with them, and I've treated many post-viral syndromes in the past, and I think it can rebadge and re-switch the organism to change back to where epigenetically it was working before. And I think particularly we know that laser works on the DNA repair protein, and that's particularly the one that's affected from the spike protein in COVID and long-haul COVID. So if we can have that DNA repair gene and the telomerase working better, we have a very good solution for this huge problem we're going to have with long COVID.
Thank you. On the fly, a quick question as well. So it seems like you use several targets, the transcranial, the cervical, the abdomen, and it seems like there's a combination of those that might vary in some of the cases that you presented. So I was curious about the rationale about using different combinations here. And also a related question, so how much of these effects are you attributing to the effect of the light on the microbiome? How many or how much of these effects are actually independent from the microbiome?
So very interesting question. We did only the cervical spine and abdomen in our Sydney trial that had 7 patients. So I didn't discuss this, we didn't have time, and 7 case matched controls. And you can see from those changes in the microbiome, they were almost equivalent between the 2 groups. I really think that the vagus nerve will influence both. So I think you're targeting it through C2. And I really think that is the most important area to treat, whether it's transcranially or abdominally, because we've got the endo restiform nucleus that we can, and the trigeminal nucleus that we can target directly into the vagus nerve. So I think that's the most important. The neurologist that was so happy with the treatment of that patient, he thinks that it was through this nucleus that we're targeting. So whether it's from the abdominal, from the vagus nerve that targets it, or directly through C2, I think that's the most important. But we can see the connectome change as soon as we put any transcranial device on the skull, and it absorbs both red and infrared, and we can change that immediately. And Professor Nays has found that if we target stroke patients on both sides, when there's a one-sided reaction for a month, we get an adverse outcome in terms of their function. And then if we put it just on the stroke side, we change it. So that's a long-standing change just by putting the transcranial. We use 3 different transcranial devices. They all seem to have equivalent. Who will be not use a transcranial device? Anybody with epilepsy, and then migrainous headache where you have severe photophobia, or any sensitizing drugs that allow photophobia. We can't often tolerate using it. So very, very sensitive people sometimes cannot tolerate the transcranial. People with very, very severe IBD, IBS, what we find is we might have to titrate the dose down because they are very, very sensitive to the abdominal treatment. We have had a few people end up with severe diarrhea with a full dose, so we've just had to really modify it. But I think all side of reactions, we call them, have been transient so far that we've seen, and reversible.
Thank you again, Anne. It has been really a pleasure, and thank you all for coming in today. This is actually the last session for the season, so we're going to resume in the fall. Please give us ideas, and we would like to have more presenters and more of this in the fall.